I'm Dr. Tiomutuloza. I'm the Executive Director of the Joint Clinical Research Center. The JCRC was established in 1991 to address the national HIV/AIDS crisis. So this was a scientific intervention in the epidemic, which was at the highest in the world at that time. So this was set up as a strategic venture at the time to maximize the scanty resources between the Ministry of Health, which provides the policy guidance, Makerere College of Health Sciences, which did provide and still provides the human resource and researchers we work with, and the Ministry of Defense Department of Health, which provided the initial infrastructure, and we continue to work with them. The vision of the JCRC is to be a vibrant, self-sustaining center of excellence in medical research, training, and healthcare services. The objectives at the time were to carry out research on HIV/AIDS and related conditions, but this has been expanded to include other emerging health conditions of interest. We provide quality HIV/AIDS care and treatment, but also other diseases that are emerging or are prevalent in our population. And we provide facilities and logistical support for training activities that support research, care, and treatment programs. This is just an overview of the different buildings at our campus, which is the headquarters of the JCRC based in Kampala. However, JCRC extends beyond the headquarters. We have regional centers of excellence across the country. Those in red are the ones that were set up originally, and those in green are centers that we have set up because of the PEPFAR work we are doing in the area of HIV/AIDS in those regions. And these centers all have laboratories that support quality assurance and lab capacity for the public sector. They provide training opportunities, and they also conduct research. These are the different sites across the country. And since the inception of the institution, there have been several achievements. I will just mention a few of them. The Joint Clinical Research Center pioneered use of antiretroviral drugs in Africa and has started the largest number of patients on ART, maybe we can say in the world. The center also pioneered HIV vaccine trials in Africa, both preventive and therapeutic. We have been part of over 100 trials, and some of these have been landmark trials that have shaped policies and guidelines in Africa and beyond. One of them is called the START study, and this study informed the WHO to change when patients can start antiretroviral drugs. We have established state-of-the-art laboratories for HIV basic and clinical research, vaccine development, monitoring of antiretroviral therapy, and these labs are now CAP certified. We have developed national network model for service delivery and provided initial national HIV/AIDS services, including viral load. We introduced viral load in 1996, and also early infant diagnosis in all the regional centers that I already showed you. JCRC has a wide research agenda, and very briefly, we conduct a lot of clinical trials for HIV and other infections. We are involved in vaccine studies. We are involved in research on TB, which is very common also among HIV patients. We have research projects on sickle cell disease, cardiovascular disease, malaria. We do research in virology, immunology, social and behavioral studies, and also epidemiological studies and pharmacokinetic studies that have led to the approval of especially pediatric treatment in developing countries and across the world. The JCRC, as already mentioned, has the state-of-the-art laboratories that are certified by the College of American Pathologists, and this is the highest level of standard any lab in the world can get. However, we still have to work very hard to sustain that level of quality. We have specialized labs, and some of these were set up with the Case Western. In particular, Eric was one, or when he was still in Case, who supported us to set up a drug resistance lab in 1999. This is now WHO and CAP certified. It's supporting both the national HIV program and regional HIV/AIDS treatment programs. We have a TB lab, which is one of the best in the country. We have immunology laboratories that have helped us to understand TB and HIV interactions and how TB treatment can be improved. These labs are one of the biggest labs in the region with a menu of over 50 tests. This is just a pictorial of the TB labs. Also, to support our research, our community networks, we have developed community network systems in all areas where we operate from. We have a community advisory board which links the center with the community to support research. And we also have a band composed of youth living positively with HIV who help us to create HIV awareness, fight stigma, and encourage treatment through music and drama in the communities. So with that overview, I think these are some of the training and internship opportunities that we have here at the JCRC. We have a big agenda in research. We currently have 19 research projects that are running, and 15 of them are in the pipeline to start in the course of the year. We take care for over 14,000 individuals, and we have created a database on how these patients are doing, which has been in existence for over 15 years. So there is a lot of opportunity for people, especially who are in statistics, to come and work together to analyze, do secondary data analysis on the database that we have. We have state-of-the-art laboratories. I've already talked about them, and also these provide an opportunity for people, especially in the lab sciences, to come and work with us. We have community-based project for TB case identification and linkage to treatment for those that may be interested in community work. As already shown on the map of Uganda, we have PEPFAR-funded programs in the north and southwest of the country, where there are a lot of opportunities and a lot of questions and on how we can improve practices in the field. We also have the JCRC regional centers of excellence where students could be placed. These are spread out across the country. And one other area, of course, is innovations. We are working with different groups that have made innovations that we are evaluating. Right now, we've been working with a group from Wisconsin. We are evaluating a simple and cheap assay for COVID testing. We are already in the process of doing that. We've also been evaluating a very simple diagnostic assay for TB using urine. What are the future priorities of the JCRC? We are looking at injectable long-acting antiretroviral drugs, and we have 2 studies in the pipeline. These are going to start in the first quarter of next year. And one of them will be for adults and then for adolescents. The one for the adults will be coordinated for Africa by the JCRC, and the study will take place in Uganda, Kenya, and South Africa. We are looking at projects for the cure for hepatitis B and C as core infections or standalone infections. We are looking at novel drugs, treatment shortening for TB and also HIV, new drugs. We are looking at multiplex sequencing for when we are doing HIV drug resistance to simultaneously screen for other viral infections and emerging infections. We are also diversifying to look at non-communicable diseases, especially cardiovascular disease. We are very keen and working in the area of HIV cure agenda and HIV reservoirs, and also transplantation medicine, where we want to pioneer stem cell transplant in the region.
As the Finance and Administration Department or Directorates that incorporates different heads of departments, including finance, including ICT, including procurement, including stores and warehouse management, including transport, and all the back office operations. There are quite a number of training opportunities that you can learn from the directorate, including issues like taking care of medical supplies. How do you ensure that supplies that are related to research and medical care are taken care of in the right condition that would meet the criteria of different protocols? How do you ensure that the logistics around, how do you bring in logistics that require medical supplies, drugs that meet the standard are done in the right way? In finance, there are quite a number of opportunities that you can also take advantage of, including learning from how do operations regarding project management, project finance related issues can be done. Also, how do you combine the issues regarding finance in a medical and research institution? There are quite a number of details that you need to learn, you would want to learn from. There are also issues regarding how do you ensure that the systems are in place that fit or comply with the different requirements of the donors. We've also had a number of systems that have been strengthened over time, including financial related systems that combines reporting and standard reporting, and combines also management of donor-funded programs, of donor-funded grants, and a number of our donors across the world have come and tested the systems, and they've found them to be sound. So we do want to come and learn from such kind of systems. For our students across the world, we want to assure you that when you come, you're going to have a great opportunity to learn from all these back office operations. We guarantee you a duty of care that when you come, for us, the student care is paramount and key, and it's a priority for us as an administration. And we shall ensure that you receive a well-coordinated program that assures duty of care. We will have very good and sound ICT platforms that will enable you to, it's a top-notch, really, ICT platform that coordinates all operations at the center, and that will ensure that you have uninterrupted internet connectivity that will allow you to exchange and communicate across the world with your parents, with your fellow students, and also to download education materials. That is something that we want to assure you that you have when you come over. We also want to assure our students that we can be able to coordinate and ensure that you have accommodation and logistics around your travel when you come over, you'll be able to get a modest accommodation that is quite affordable, and to ensure that you're comfortable when you're here, and your stay will be really something that you'll ever talk about. In case you require letters of support for your travel, that is something we shall do, and ensure that we coordinate with the ministries required, the embassies required to have letters of support, that your travel is easy, and all the administrative and logistics around your travel will be quite very good. We wish to welcome you to the JCRC, the Center of Excellency, and we want to give you a comfortable and life-experiencing placement that we'll talk about. They'll be able to even call other people to come and have a taste of this placement.
The clinical directorate, I can say, is the directorate with the largest number of staff at JCRC. It comprises of several units. It comprises of the adult outpatient clinic. There is also a pediatric outpatient clinic. Where we are seated right now is the private clinic. And then we also have a 15-bed inpatient facility. So it is in this clinic and the ward where we actually interact with patients, through consultations and offering treatment. There are other units in the directorate that actually support these big clinics. For example, we have a radiology unit that offers X-ray, digital X-rays, offers ultrasound services. We also have a pharmacy. We also have smaller units, like we have a dental clinic. It's actually quite a modern dental unit. It has the latest equipment. It's currently manned by a dental officer. We also have a cardiology unit. It's also manned by a registered nurse. The cardiology unit, basically, apart from doing consultations, it also has the capacity to run ECGs, electrocardiograms, and echocardiography. The most recent addition to the clinical directorate as a static unit has been what is called the apheresis unit. The apheresis unit is a procedure we use for removing harmful substances or cells from the body and replacing them with other fluids or substances. For example, we use it very commonly in red blood cell exchange for sickle cell disease patients. The aim of that procedure, for example, for sickle cell, is that it reduces the percentage of sickle cells in the blood. So it doesn't cure sickle cell, but it reduces complications. Our apheresis unit is the only unit in the country.
So here is our reception area. We have over 15,000 patients that we take care of. This is one of the biggest clinics in Uganda. So this clinic, like you may have heard, started way back in 1991. Okay, so we've had patients that we followed up for all those years, and therefore we had a cumulative number over time. A card just looks like this. There are no names. You can't know anyone. So for purposes of stigma management, there are no names, and we have, of course, to keep confidentiality. So it's one of our training. You keep confidentiality of your patients. So we know the date of birth, we know their gender, we know when they started the ART, and inside here, just an appointment. Okay. So we have, when the patient comes through, they see this lady here. She's the first person that interacts with all the patients, so she's very, very busy. And the first stage is to do their triaging. Triaging is basically to take their vitals and everything. And the officer in charge at this station of the loop is none other than a remopeter. Once they're distributed to the various rooms in the doctor's places where we are going to go next, we are able to interact with them and do what we call a clinical assessment. And that's where the gist of the matter is, the technical bits go in. We have, this is an example of the doctor's office. We have over 4 doctors who are able to assess these patients when they come through. They do their history taking, they do the physical examination, and they note everything onto the computer. Every patient has a page where we write those clinical monitoring notes. Now, the diagnoses are then written out into what we call ICEA. It's a platform where we interact as doctors to show what sort of diagnoses the patients have had, and they're able to help the next doctor who will see this patient follow up.
Because it is entry to the treatment, we do HIV testing and counseling for both adult and babies and children, and those who test positive, we put them on care, and we handle clients with psychosocial issues, because as you know, like HIV is one of the cause of trauma. People have depression. Because of that, some stop taking drugs, they give up in life. So when it happens like that, we counsel them and then they come back to life. So we do a lot of that. Someone can say like, I'm tired of taking these drugs, if I die, I die. So you have to tell a lot, counsel them to change the negative attitude to positive attitude, and life continues. So we have also clients who have poor adherence to treatment. So as you know, like the successful of treatment, you have to have and take the by road. So when we find those ones, we give them what we call intensive adherence counseling. So it means you have to go dig in their life style, or sometimes even you visit them at their homes and help them to take the drugs correctly. Then we also go to the communities, because like we can't be and we are not in the communities where the parents live. So sometimes we get program where we go and test the community around. We test them for HIV. And we start on them on drugs the same day. So everything is done in the community. So afterwards they come here and continue from where they started from. So we've been having students who come to learn the skills, the theory. They learn theory in the universities, then they do practical from here. We have students from, we normally host students from Makerere University, Chambo University, Mukono University, and yeah, those famous universities who have their social work and counseling faculties. So they come and work with us. They learn how to practice counseling in a real sense, not in a theory. When our patients come to the clinic, they start to the reception where they are registered. The people you see at the reception are peer supporters. They help us to identify adolescents with problems, because it's easier for them to interact with their peers compared to us. We have 2 groups of patients. We have the general patients and we have patients who participate in research. This is where the different coordinators sit, the coordinators for the different trials. It's a big room, and that's where the files are. This is to the phlebotomy area, where the children come in for the blood draws, both the general patients and those who are participating on trials. We also participate in trials that involve pharmacokinetic studies, so everything is handled here.
Quality improvements is broad, it is big, but one of our major roles or core values is to ensure quality within the systems as well as managing of our clients at JCRC. This team works with a broad number of people, and it cuts across right from the gate to the extreme end through to administration. But majorly within the clinic activities, we help identify areas of improvement, that we work closely with the people that are in charge of certain departments to ensure that we have smooth running of the clinic. We support the clinic in that if there are any issues or related complaints or something from the clients, we address the issues and we resolve them to ensure continuity of their treatment. We also manage the patients that have been lost to follow. We follow them up, give them calls to find out what is happening, how they are doing, and how best we can get them back to the clinic.
So this is our apheresis unit. This is the waiting area. Relatives gather here as they are working with the patient within the unit. It is the spectral optia apheresis system. And this unit can do multiple things. It can do red blood cell exchange, it can do plasma exchange, it can do collections for platelets and plasma. Actually, we are even planning to use it in COVID-19 treatment. So basically we collect plasma from patients who have ever suffered from COVID-19, and we use the antibodies in that plasma for therapeutic purposes.
Radiology department will have a digital X-ray system and also have a high definition portable ultrasound unit, whereby you're exposed to lung conditions, bone conditions, soft tissue conditions, and with high technology, learn how to interpret, because we have a senior consultant radiologist who is at our disposal for consultations. This is a workstation where we control radiation from, we enter patient data from, we see exposure from, we choose the projections from, and we're able to post-process from here and then print from here digital copies if we want. We can also send them digitally to whoever we want it to send to. And then of course this is our exposure console. So this is a panel where we calculate which dose to give you, which projection will I be taking, and which part will I focus on. All are manipulated from this console. In the examination room, this is mainly an X-ray that is digitized. It has what we call flat panel detectors. This is a flat panel detector that receives X-ray radiation, converts it into light energy that is taken. I told it is wireless, so it is picked up by the Wi-Fi system there and then able to demonstrate it or portray it on the monitor. So it is radiation controlled. So everything is regulated very well.
So when you're going to sterilize instruments, we always first wash them from inside, like I'm going to show you. Then we come here and sterilize them. We have our functional dental chair. So this dental chair works and it functions very well. We operate it from here. That's where all the movements are made from here. Here we have the intraoral dental camera, which is working, as you can see. This one helps us to take pictures from inside the mouth for the client to easily see, so that whatever we are accessing, the patient is also aware. Here we have our dental X-ray. So the X-ray also works, and we take our X-rays from here in case of need, which is very necessary in dental procedures. Then all the materials that are needed, we have different kinds of materials. We do procedures like scaling and polishing, what most people call cleaning of teeth. We do filling, dental conservation, most people call it filling. We do root canal treatment, whereby we remove the nerves and they stay in the mouth. We do extractions if necessary.
It was opened in the year 2013, and mainly it was for echo and then ECG, which we do to cardiac patients. Mostly we are dealing with rheumatic heart disease. We went to school screening them, and then now, when those who are confirmed with the disease, we give them prophylaxis of injections. Here in this clinic, we also do ECG. They also learn how to fix these electrodes on the patients, and they know how to at least do the procedure for doing ECG on patients. And we also have the ultrasound machine. When they're here, we also watch the ultrasound being done. And there they are also taught, because in the ultrasound, like echo or ultrasound, they can see the organs, internal organs.
Patients come to healthcare facilities. At the back of their mind, they expect to go with medicine. If they don't go with the medicine, even if they have seen the best clinicians, the best caregivers, they don't feel they have been properly served. And therefore that put pharmacy at the center of the activities that we do here. So as pharmacy, our core activities are, one, to ensure that we have the ARV commodities that the patients need. Good enough, we have guidelines which stipulates which drugs to use, so selection of the commodities is no longer a challenge because we just follow what's in the guideline. And the Uganda ART treatment and prevention guideline is adopted from the WHO guideline. And almost all the research activities ongoing at JCRC have drug component. So again, the pharmacy team play a very key role in research. Our key activities under the research is one of them is to advise the researchers on the regulations regarding drug related studies. What are the requirements for submission of the protocol, what is called clinical trial application, to the different authorities. The most important one, or the critical one, is the National Drug Authority. Yeah, so where we work with partners outside Uganda, some of the drugs are either not yet even registered in Uganda for clinical use. So those ones, we need to advise the researchers on the steps to take so that we obtain all the regulatory requirements and documentation in place before the study actually begins. Once you have imported the study drugs, they have to be stored under stipulated conditions. Those conditions are stipulated by the manufacturers of the different IMPs. So we ensure those conditions are in place. The controlled temperatures, where refrigeration is required, we have refrigeration. But also we know power outages in Africa is a common thing. But for us here in JCRC, we have standby generators which automatically start within 3 seconds. Yes.
Thank you.
As you can see, this is control entry. Whoever enters here has to be either the pharmacy staff or access granted to him or her by the pharmacy staff, because it is fingerprint, and I'm the one who allocates to the pharmacy staff. So this is the main store for the pharmacy. We make requisition for drugs from the stores, from the main warehouse, once a month, because we know the regimen that these patients are on. We know the visits are scheduled in terms of appointment, so we can know in advance how many patients are expected within a month, within a week, within a day. So based on that, we project the requirement for the month and make a requisition. So we do, to manage the stock and do accountability, we do physical count once a month, and we reconcile what we have counted vis-a-vis what the card says. If there is any discrepancy, that is investigated and resolved. This is a quarantine area for drugs that have expired. So these are waiting for audit to come and verify, and then we move them from here for destruction. This is the main dispensing area for the pharmacy. Drugs are replenished in this section from the stores on a daily basis. Like I already said, we know the average number of patients coming on a daily basis, which I've already mentioned, 200. So we make a transfer from our main store to refill this area, and then we dispense to the patient according to the prescriptions that come. For cotrimoxazole, which is still being given as a prophylaxis to the majority of the patients, we do prepackage the Septrin. The prescriptions come online. We have a clinic, integrated clinic enterprise application, which is the database that we use for the clinical care of our patients. So on it, the prescribers take the medical record and do the lab request, and eventually make a prescription. The prescription automatically comes to pharmacists.
This lab, it is a two-story building, and it has done a lot of both research and clinical work in Uganda and outside Uganda. And this is the largest lab in East Africa, accredited, with the over 60 tests, to simplify, over 60. And we maintain all those tests on external quality assurance, in brackets EQA, and all of these materials are supplied by College of American Pathologists. We have a biorepository, which I'll also walk you there, with over 40 freezers. That's -80 freezers, where we store our samples. And these samples are for future storage and future tests, and others are for shipping to the respective collaborators we work with. Before we were struggling with the drug antibiotic resistance in the population. We participate in this by doing some research. So we want to be involved in looking at antimicrobial resistance, both in humans, animals, and environment. So the samples will be collected from these different communities, and we see how this drug antimicrobial resistance is transmitted and what mitigation measures can we have. And we still call upon the researchers for support.
This lab is a research lab and clinical lab, and we mainly focus on HIV drug resistance as research and for patient care. So as a clinical lab, we are part of the national program for HIV treatment, in that we monitor all the patients who are on antiretroviral drugs by doing a drug resistance test for them. And also being at JCRC, we also take care of the patients who are on treatment, because with treatment there is need for monitoring. So we monitor these patients to see that they are responding well to treatment, and then for that we do a viral load. That's the first line of monitoring. And those that are not suppressing, because in the first year you have like 10% of patients not suppressing, in the second year about 20%, then we have to ask why aren't they suppressing. With that background, we do a drug resistance testing, and basically what a drug resistance testing is that we are looking at, normally when patients are on treatment, the virus tries to run away from the drug, to escape drug recognition, and by doing that, it causes some mutations within key areas where the drugs bind. And when it causes mutations there, then the virus is not able, the drug is not able to recognize where to bind. And so then the virus has the liberty to replicate. So by doing a drug resistance test, we are able to ascertain which patients are taking their drugs well, and which patients even if they are not taking their drugs well, they are not adherent. We sequence that region that we have targeted, then we look for those particular mutations that will confer resistance or escape of that virus from the drug. The gold standard we use is the Sanger sequencing. It has been around for many years, but it has a limit of detection, which is about 20%. So anything below 20% you cannot detect. So that is the limitation of that method. But with current technology, we see that now there are more methods that are newer, and you're able to detect these mutations as they come in. So you can detect mutations as low as 1%, and that is using the next generation sequencing. This sequencing is called deep sequencing, whereby the virus is sequenced at great depth, and you're able to detect very, very low frequencies of this virus. So this is good for patients who are starting treatment, because if you find these viruses at low frequencies, then you cannot start a patient on a drug that the patient has low frequency mutations on. And also for patients who are already on treatment, the doctors can decide that, well, if this mutation is coming up, most likely within a short time, it will be up to another percentage, and it will cause cross-resistance. So it helps us to detect mutations early, and then change treatment for the patient so that the patients can thrive well on their medications and just lead a normal life.
So in the hematology section, we do the routine hematology tests like full blood count, blood smears, but we also do blood transfusion medicine. The National Blood Bank provides us with blood units for transfusion. We receive the blood and record all the details in this file that we have hidden. These are our documents for the blood transfusion. We receive the files from the blood from the
national blood bank. For them we keep them in our blood banks, as I've shown you, with our local temperatures. We are very specific about this.
And in our clinical chemistry lab, we have two sets of equipment. One does the routine chemistries, and then we have the other machine doing the immunoassays and the cardiac markers. This is the Architect Abbott analyzer. It does the immunoassays, and by immunoassays I mean tests like toxoplasma, cytomegalovirus, hepatitis B serology. We also do P24 HIV combo, and we also do cardiac markers on this machine. And then on the other hand, we have the Cobas Integra. This one does the routine chemistries, the liver function, the renal function, the lipid profiles, and all drug toxicities are done on this analyzer.
Microbiology, we have a range of tests we do. We shall begin the simplest tests we do, the serological tests. We have this BACTEC machine, which does blood culture. This helps to rule out sepsemia in HIV patients. This is an HIV center. We also have we do bacteriology using this robust machine called the BD Phoenix 100. This is a big machine, analyzes 100 specimen. 100 specimen within 8 hours. We also do lots of parasitology, stool parasitology. We isolate parasites in stool in human beings, more so in the HIV setting here. This is a fume hood where we do our isolation and staining of the protozoa isolated from the stool. This is a technique that helps you not to miss out even the hidden parasite that you would have missed using other methods of concentration and direct wet preparation. We also have other tests we do, which include the mycology. We look at the yeasts. We identify yeast in HIV patients, also cryptococcal nymphomans, and also several species of Candida, which isolate and differentiate them to provide the clinicians. Still, all these things we isolate, we use the BD Phoenix to help us identify the organisms and also the drugs of choice to use. And this shall guide the clinicians which drugs are sensitive, which are resistant, which goes back to the antimicrobial resistance, which has become a challenge in the country because people are buying drugs over the counter, not knowing if it will be effective and doing self-treatment.
So this is a biorepository lab where we keep all samples that we receive from our research protocols. We have over 50 freezers, and these freezers contain different samples for long storage. We have a system that manages monitoring temperatures for these samples. It is automatic 24/7. We receive messages on our phones, we receive messages on our emails in case the freezer is out of range of temperatures. We're also planning to install a solar system that will be able to back up the power system. We're also planning to buy a machine that will be producing dry ice for our shipments. So we have keys that nobody should come in and try to open because we always have safety of these. So we have keys that we use to open. And when you look at all, they are almost full. These are samples that we've been storing for the different protocols. We also get students that come in and do trainings in here, how to manage samples, how to store them, how safe they are for long storage, for other future uses. Yeah. So we give
them names to identify them from other freezers. They have different names. There is Josephine there, we have Isan there, we have Sisi as our ED, that is her freezer named after her.
Firstly, why we do community programs is that we are aware of global shortages in health workers. We are aware of the poor distribution, especially for low developed countries like ours. The distribution of health facilities is so poor, and there are performance gaps, and the health workforce is so thin. So such gaps are actually normally met by structures on the ground. Structures emerge on the ground to fill these gaps through the private sector or private not-for-profit. So these come in to meet these gaps, and community-based organizations which are embedded in the community present a very good approach to be able to meet local needs at a domestic and community level. So we design these programs based on how we want to reach the communities, the need that is there, and how we want to create a sustainable outcome, not just basically doing an intervention and getting out. This is outstandingly, it has become a hot potato, because community programs actually bring the point home to the community, bring it to a domesticated community level, where you in fact have a solution that the last man understands, and that last man's change, or that last man's change in behavior about their health, will bring about an improvement and a change, in the direction which you want, depending on what you are targeting.
We have other centers in Mbarara, in western Uganda. That's about 4 hours from Kampala by road. And we have other centers in Fort Portal, which is again about another 4 hours, and another center in Gulu, which is 5 hours, and another center in Lira in northern Uganda, which is also about 4 hours by road from Kampala. And in those, what we here call up-country sites, some of the centers are involved in clinical research, and also we have one particular center which is not involved in clinical research. That's the one in the northeast Uganda, which at the moment we are running a community work. It's targeting comprehensive HIV services, HIV and TB services, but it's based in the community. Our work there is mainly to increase access to HIV care services and prevention, and also to increase the uptake of those services.
Some of the models we are using in the community, we are using the model of village health teams as well as CLVs. The village health teams are the people we find in the village, in the community, who help us access the key population that we want, the kind of people that we are looking for. We don't normally do an outreach just like that to target the whole population. We normally go out looking out for specifically certain group of people who are highly at risk with this HIV virus. We identify the hotspots in the community, which kind of hotspot is there. So we look out for those hotspots. We penetrate through them, through their peers. Those peers help us identify those other colleagues of theirs in the community. The kind of outreach we do at that time, it's called a moonlight. It's named moonlight because we target people at night, and then the moon is the one that lights us as we do our work. However, we have torches, we have other things to help us out as we carry out the activity, but they named it moonlight. So we go out to meet them at that time when they are working. That's why we call it a moonlight. So we find them at their workplaces, and then we offer to test them, free HIV counseling and testing.
We also are implementing pediatric and adolescent case finding, and we have vetting strategies that we've implemented to ensure we retain patients on care, because that is the biggest challenge with most of the facilities in the country. You can identify positive, but retaining them on treatment is not easy. So most of the approaches we use is to use root cause analysis, finding out why they don't come back to the facility. But also we have a team that is actively calling these patients to make sure that they keep appointments and find out why they are not keeping them. Here we are also implementing the differentiated service delivery model at the facility, and this includes multi-month drug scripting, which may include also 6 months prescription, where the patients are given drugs to last for a long time to avoid them moving back and forth to the clinic, and also to improve identification and ARV coverage of men and adolescent groups.
The primary role of the department is to provide data management support to healthcare, research, and training. We provide data management support to healthcare at our clinics and the laboratory in all our sites, including the regional centers of excellence. We provide data management support for now more than 20 years, beginning at the height of the HIV/AIDS epidemic. So over time, we have built large databases, and this probably provides JCRC with a unique opportunity to support scholars, learners, and for training. And so, anybody coming to work with us will get a wealth of experience on the top-notch current databases. We're talking about the SQL Server, we're talking about the integrated systems, we're talking about the lab information management system, we're talking about the integrated clinical enterprise application that we're running here. When the HIV epidemic started, we're using paper-based systems. You will also be able to learn the transition between paper-based system to wholly electronic systems.
So basically, a paper-based system means that we just write details to do with the patient's episodes and history and all that in the file. At that point, we do not have a computerized system. We have the daily backups, and then we do weekly and then monthly backups to ensure that everything is safe and therefore can be accessed by anybody when we need.
We are doing mostly research on HIV and AIDS in the beginning, because that was the main reason why the institution was born. But also we touched on things like TB and some cancers that are very much related with HIV. As you know, TB and HIV kind of go so much hand in hand, especially here in the developing countries. So, but over time, as more treatment options have come on board, people are living longer with HIV now. It's no longer as a death sentence as it used to be, because now there is at least an option of treatment. If someone takes their treatment well, they have a chance to live a normal and productive life. But then we have seen an emergence of other health conditions that are now a problem to people living with HIV. These include cardiovascular diseases, includes some cancers, and a host of other things, some of the uncommunicable diseases. So because of that, we've had also to focus on them as well, so that we don't focus on not just HIV/AIDS, but also we are now doing research in some of these other conditions. We have done research with the in collaboration with other research institutions within Uganda, but also outside of Uganda. We've also have now an opportunity to pass on some of the experiences that we've learned along the way in terms of research itself, the knowledge that we have acquired along the way, the experiences, and over time we've become a knowledge hub. We are doing research in human beings, and there's a lot of things that can go wrong on that. So we have independent bodies that come in to look at not only the science of what you're going to be doing, but also the ethical aspect of it. The ethics committee doesn't stop at only reviewing before the study starts, but they also go on to follow up the study, to monitor it. Is it being implemented according to the protocol, to what was approved? So there's those monitoring visits that ethics bodies do, or we call them inspection visits, to ensure that the research team is still compliant with what they set out to do and what they wrote in the protocol that was approved. We do report as we go ahead, because sometimes you get, you may not, you find that you, for one reason or another, either by commission or omission, you deviate from what you set out to do in the protocol. Okay? Some various reasons come for that. But how do you report that? Because every time you deviate from what you set out to do in the protocol, it has to be reported to the ethics body. Okay? And so students need to learn that. And then also sometimes you get what I might say is maybe side effects or adverse events that may occur during the study. So how do you report them? What are the timelines? Where do you report them? So all that is very important. If all that is not well done and well handled, then the research either becomes very dangerous to the participants themselves, or the information that is coming out actually is not a true representative of the nature of what you're trying to research on. So you have to be very meticulous in all these aspects.
I work with a team where we have representatives from different departments. That's the training committee for Joint Clinical Research Center. Basically, it advises the management. It is involved in developing training manuals, short courses, together with the other collaborators. But we also work with them to write research training grants. We basically manage the trainees when they come here, the different categories of trainees. Some are students, postgraduate, undergraduates, and some are employees from different health institutions, academic institutions that come here for placement. So they go to different departments, so they are attached to these different departments once they come here. But there is also an opportunity for the students to rotate. If they want, they pick interest in some aspects of one department, they can move and go and attend something they want in a department. For example, somebody may come in finance, but may pick interest in community engagement activities, may pick interest in what is happening in the counseling. So they are free to go there. So what happens is that students do apply, it goes to the executive director for approval, and then comes back to me and this office, and then we write the students the acceptance letter. There is also an opportunity for students to be paired.
That was the brief overview of what the JCRC has to offer. We would not have achieved what we did without partnerships and collaborations in order to achieve that work.
you.